Hello, my name is RJ Rruble, and I'll be presenting on reporting lung transplant complications in the acute setting, a primer for ER radiologists, and I have no disclosures for this presentation. I first want to start by talking about why it's important for ER radiologists to be familiar with lung transplant complications. Lung transplantation is an effective treatment for patients with irreversible end-stage lung disease, and prevalence has increased since its advent. While post-transplant management has improved over the years, these patients remain high risk for developing life-threatening complications such as infection and graft rejection. Therefore, it is important for the ER radiologists to be aware of the unique features that pertain to post-transplant patients in the ER setting in order to accurately diagnose, triage, and manage these patients to improve outcomes. The first complication to review is rejection, which is an unfortunate and constant threat to the transplanted lung. Imaging features of acute rejection, typically occurring from 1 week to 2 months after transplant, are nonspecific and overlap with other diseases. Most commonly, CT will show regions of ground glass opacities and interlobular septal thickening, indicative of the acute inflammatory nature of this disease. While some patients with acute rejection may be asymptomatic, those seeking emergency care for it often present with fever, cough, and shortness of breath. Here on screen left is an axial CT of a patient with prior lung transplant who has some shortness of breath, found to have subtle areas of ground glass opacities, and they were found to have acute rejection. Chronic rejection typically occurs about 4 months after transplant and presents with small airway disease imaging features, including bronchial wall thickening, mosaic attenuation, and bronchiectasis, all pointing towards bronchiolitis obliterans, one of the two phenotypes of chronic lung allograft dysfunction, the other being the less common restrictive type. The second complication is bronchial stenosis, which is actually the most common complication after lung transplant, and this most often affects the anastomotic site due to inflammation and scarring. It tends to develop within the first year after transplant, but it can occur later and presents with lower airway obstruction symptoms such as wheezing, cough, and post-obstruction infections. Here on screen left is a coronal CT zoomed in on the left mainstem bronchus, which is nice and wide open, patent, no obstructions, and this was the patient's prior. And here they are on screen right, presenting with acute worsening shortness of breath, found to have a large PE, which is not shown, although also incidentally found to have some endoluminal narrowing due to inflammation and scarring here at the anastomotic site due to bronchial stenosis. The third complication is COVID-19. Lung transplant recipients are a high-risk immunocompromised population, and COVID-19 is no exception. Imaging features often overlap significantly with rejection, and serologic testing is crucial to assist in differentiation. Treatment is similar to the non-transplant population, and prevention is critical. And here are two axial CTs demonstrating diffuse geographic ground glass opacities in both lungs, and this patient was positive for COVID-19. Next is pulmonary embolism, which can be devastating to the lung transplant recipient, and they are at increased risk. This process is multifactorial, involving post-surgical status, long recovery periods, and reported associations with some anti-rejection maintenance therapy regimens. Some of these medications are also associated with renal toxicity, which may preclude patients from receiving IV iodinated contrast. This situation may therefore call upon ventilation perfusion imaging to help make the diagnosis. And here is an axial and coronal SPECT CT demonstrating a large perfusion defect in the left upper lobe, indicating a high probability of PE. Next is pneumothorax, which is very common and expected in the immediate post-transplantation setting, given the nature of the surgery. Spontaneous pneumothorax after recovery from transplant is relatively uncommon, and when detected, it is important to consider that a more severe complication may be present, such as a bronchopleural fistula. And here are axial CT of this patient presenting with weakness and dizziness and prior lung transplant showing a trace right pneumothorax. Lastly is bronchopleural fistula, which occurs as a result of abnormal communication with bronchi and the pleural space, leading to continuous retention of air. Donor recipients who are at increased risk of this complication include those with prior lung resection, which is often performed to better fit the transplant lung into the recipient chest cavity, or for resecting complicated infections, such as necrotizing pneumonia. Treatment is often surgical. Here's a coronal CT zoomed in on the right lung of this patient who had prior lung transplant with fever and cough, found to have a right lower lobe necrotizing pneumonia, ultimately was resected, and unfortunately developed an expanding gas collection in the pleural space, found to have a bronchopleural fistula. And this patient underwent a unique procedure called an Elios or flap reconstruction. With that being said, I hope you've enjoyed this presentation and are now primed to recognize some of the different presentations of lung transplant recipients in the ER setting.